Thank you, Zaifa, and thank you to Imasa and also to Serbia for sponsoring this talk. Ladies and gentlemen, as Zaifa mentioned to you, I do have a very special interest in hypertension. It's actually a personal one for me because when I was 14, my dad had his first stroke. Little did I know that one day I would pursue the enigma of this disease that is also proverbially called the silent killer. I trust that what I will be sharing with you tonight will be something that you can take home with you in your everyday practice, that you would be using these practical pearls of advice, tips and tricks, as we call them, to assist you in helping your patients to live with their disease. Because remember, this is a disease that needs treatment for life. So it's not a life sentence. As I told you, I have a family history. My brother is also hypertensive, and but with the right lifestyle choices and management with tablets and other device therapy, which I'm not going to talk about tonight, there is actually hope at the end of this dark cloud. So these are my conflicts of interest. Serbia is sponsoring the talk, but I've also done some talks for Novartis, and of course Medtronic sponsored my renal innovation project. And what I will be sharing with you tonight is my personal opinion. So you cannot hold Serbia Laboratories responsible for any mistakes that I make. And if it's okay, we can talk about it at the end if you spotted any mistakes and you want to, alert me to that. Let us quickly look at your attention span. I know that at the beginning of our talk, you're going to ask me, but why is there so much text on these slides? And when you see that there are 37 slides, and that's a lie because there are actually only 30, and I think we're down to 28 now. So in about 20 minutes from now, you'll start checking your phones, just a bit to see who is WhatsApping you or your Facebook or whatever. Unless, of course, I call you on your name, and then your attention also increases. And then at the end, I don't know, maybe most of you had supper already, but I didn't. So yeah, I'll definitely be thinking that towards the end of our talk. So this is the overview. We're going to speak about uncontrolled hypertension. This is really a very interesting topic for me because, the issue of control. Very few people who have hypertension actually have controlled hypertension. We're going to look at the prevalence of uncontrolled hypertension in sub-Saharan Africa. We're going to speak about drug adherence as to being the most common cause of uncontrolled hypertension. We're going to talk a little bit about triple therapy. Most of the talk is going to be about triple therapy being actually given to the patient as one tablet. And that for me is amazing because that you can give 3 drugs as a single tablet to people, and that you actually do see some very good results with that. And I'll talk at the end also about my experience with that. So the prevalence of hypertension in sub-Saharan Africa is estimated to be about 30%. And that means if you were to measure the blood pressure of about 1,000 people, 300 of them would have hypertension with a measurement of more than 140/90. And of those 300, only 80 of them would know that they have hypertension. So 220 of them, this would be the first time you tell them your blood pressure is high. And of that 80, only 14 are treated for hypertension. Now, I mean, if you ask yourself, it means that 66 of them are actually not treated. And the question there is, why not? And of the 14 that's treated, only 1 of them is controlled. So these are staggering statistics. And as you can see, it was published in the Cardiovascular Journal of Africa 4 years ago. And I think as we speak today, I have an inclination that the numbers may actually be higher, and it's climbing for even higher. So it's also well known that 30% of patients will be controlled on one drug, and 40% of the people that you see in your practice, they will actually need 2 antihypertensive drugs to control their blood pressure. But there will be this 30% part of the donut that may need 3 or more drugs to control their blood pressure. And this was seen in an international survey conducted in 26 countries, including Europe, North America, Latin America, the Middle East, and Asia, as well as Turkey, where they looked at more than 18,000 patients. And these were the statistics that they found, that 30% of people will need 3 or more drugs, antihypertensive drugs, to control their blood pressure. And what do you do then if, you know, the blood pressure is not controlled? So do you actually double the dosage of the agent that you've started with? Or would you consider, so that is there in gray, or would you consider adding a drug from another class? And here you can see the incremental blood pressure reduction ratio if you add another drug from another class versus doubling the dosage. And you can see that you get a much better lowering of blood pressure than increasing the dosage of the agent. So that, I think that's the first point, that if you are going to add another drug, you'd obviously choose it from another class and not from the same class. And there, essentially, you have your 4 classes at the bottom. And that you don't double the dosage, because it's also true that if you double the dosage, your side effect profile will probably also increase. This was an interesting study that was performed in Australia, where they looked at the combination of amlodipine and perindopril, giving it as a single pill, so it's 1 pill with both agents, or 2 pills containing, amlodipine and perindopril. So it's single pill versus 2 pill strategy, and they followed the people for 48 months. And what's interesting is that you'll see that the adherence over time, over those 2 years, the adherence actually decreased, even for the single pill people. After 2 years, about, let's say, 40% of the people didn't take the single pill anymore. But it was more, and statistically more, for people who took 2 pills. So that's the first point, that if you give a single pill, yes, you may experience side effects, but those side effects may be less than giving 2 pills. And number 2, that you actually increase the adherence to therapy. Because, I mean, you have that conversation with your patients every day. Doc, why must I be on so many pills? I don't like drinking all these tablets. So especially now you have a diabetic, who has glaucoma or even cholesterol and rheumatoid arthritis. It's just an endless list of pills. And frequently, the moment I start writing up more than 5 tablets, I ask myself, I wonder how many of these tablets this patient will be taking. So I asked him, do you really take all these tablets? It's quite a lot. So I think the strategy should be, obviously, that we should try to reduce the pill burden if we want to make sure that people drink their tablets. And the issue of combination therapy is therefore very strategical and helpful to increase adherence. It's also interesting that in the same study, apart from getting significant adherence with a single pill strategy, there was also a reduced mortality in the single pill strategy compared to taking 2 pills. So you'll see that at 4 years, 20% of the 2-pill strategy people already died. And I guess my dad would be part of that statistics because he died of his stroke within 2 years after being diagnosed. Why? Because the tablets gave him side effects, and he found out that when he stops the tablets, he doesn't have those side effects. So be very careful of this point that, you know, you want to make sure that your patient takes his tablets. And the strategy, and we didn't have single pill strategies, you know, when I was 14, but combining pills in one single pill improves adherence and also reduces mortality. That's a very important take-home message, I think. So these recommendations to increase adherence, there are actually 9 of them. I think the 2 most important ones for me are that you would reduce polypharmacy, that you would definitely consider using single pill combinations. And I know immediately colleagues from the state sector would say, well, we don't have single pill combinations. Yeah, you're right. I mean, that is true. But it's definitely something that needs to change, because why should single pill combinations be more expensive than, you know, double pill, separate pills? As a matter of fact, you're just giving 1 pill, not 2. And then also when you prescribe antihypertensives, it's sound advice that you give the doses once daily and not over multiple times. Like take Aldomet, for instance, you'd give it like 3 times a day. By the way, Aldomet is only used in pregnancy. It should preferably not be used for essential hypertension, because there are other more effective agents that you can use. So this is just the summary of the first part, that the majority of hypertension patients are uncontrolled. And one of the reasons that contribute to poor control rates is treatment inertia. That's you and I sort of delaying that, you know, we're going to start writing the prescription for the patient. And then also that we don't use combination therapy. Maybe it's not available as it is in the state sector, but also because we think that it's more expensive, which it may not necessarily be, because there are also now clone drugs available, not the original agents anymore, which are much cheaper. And then several guidelines actually recommend single pill combination treatment for hypertension patients as monotherapy. Why? Because combination therapy improves adherence and therefore better blood pressure control. And if you have better blood pressure control, you also reduce mortality, like I showed you in the Simmons study just previously. So why should the single pill triple combination of Perindopril, indapamide, and amlodipine be a recommended choice? I'm going to try and give you 5 reasons, and I'm going to try and keep it short. Number 1, because there's synergy between Perindopril. You can just mute your mic if you don't know.
I've muted all the mics, Doctor. You can just unmute yourself again.
Yeah, I did. Thank you. So these agents, Perindopril, indapamide, and amlodipine, just quickly about the mode of action. As you know, Perindopril is an ACE inhibitor. It inhibits the ACE enzyme both at the plasma and the tissue levels. That's important, you know, because in my second year, I didn't know that there was also an ACE enzyme in the tissue. I thought it was just in the blood or in the lungs, you know. But yes, you also get ACE enzyme in the subendothelial tissues. So if you inhibit the ACE enzyme there, obviously you will reduce the production of angiotensin II, which is the end product of the RAS cascade. And by doing so, you will also inhibit the degradation of bradykinin. That's very important. So bradykinin levels actually increase. This is why ACE inhibitors have the cough as side effect, because of increased bradykinin levels. But if you increase bradykinin levels, you also increase nitric oxide levels, which is important because nitric oxide is a vasodilator. We use it in cardiology, obviously, under the tongue, to open up coronary vessels. But ACE inhibitors actually also increase nitric oxide levels, and Perindopril apparently does so more than other ACE inhibitor agents. And we can talk about that a little bit later. But Perindopril also reduces vascular inflammation and apoptosis, which is interesting because this may have benefit for atherosclerotic plaques. So if you reduce inflammation in a plaque and you reduce apoptosis, you stabilize the plaque, and therefore you prevent rupture and acute coronary syndromes, etc. So indapamide, it's a thiazide-like agent. It's a diuretic. Obviously, it increases urinary excretion of sodium and chloride. But unlike the other diuretics, it has neutral metabolic effect on the lipids and the glucose. And it also gives you less gout, for instance, than hydrochlorothiazide. Amlodipine, well-known agent to many of us. It's a direct vasodilator. It's a calcium channel blocker. It prolongs the inhibition of the calcium entry via the slow channels at the level of the myocardium and the smooth muscle cells. So amlodipine also increases the glomerular filtration rate and the renal plasma blood flow, and the vascular resistance in the renal arteries are also decreased. So you can see that these three drugs coming from different classes work together as a team. A very good team, I must add, and I don't think I'm biased when I say that, because you reduce side effects if you combine them together. We can also talk about that a little bit later. Secondly, I think it's a good combination because of its effect on blood pressure. And here you can see, if you look at your ACE, ARBs, calcium channel blockers, and diuretics, the different classes that we know, that Perindopril is actually the only RAS inhibitor that gives you 100% cover over the 24 hours. So it's 75 to 100%. But compare, for instance, Perindopril to enalapril. And there you'll see, if you drink it in the morning, by midnight, most of the drug would be gone. That's not the case for Perindopril. The same for amlodipine. If you compare amlodipine to nifedipine and lercanidipine, it also has 100% cover over the 24 hours. Look at indapamide compared to hydrochlorothiazide. You'll see that within 6 hours after taking your hydrochlorothiazide, the drug is finished. There's no more diuretic effect. So does it mean that you're going to urinate the whole 24 hours with indapamide? No, it doesn't, because remember I told you indapamide is a diuretic. So yes, it gives most of its effect is through diuresis, but it also has vasodilatory effects. So I think this is an important point to make, that these agents would give you true 24-hour cover, not just by working together as a team and reducing the side effects that we normally expect with these agents, but because they work together, you also get fewer side effects. These are just two trials, the Pianist and the Paint study, that where these agents were tested in, well, if you add it up, more than 10,000 patients. In Pianist, you can see the blood pressures at baseline were quite high. Obesity, smoking, all those risk factors that we see every day. And these hypertensive patients were switched to Perindopril and indapamide plus amlodipine, or Perindopril and amlodipine plus indapamide. And there you can see that, yes, this is what you will get after 4 months in average. Reduction in blood pressure with systolic blood pressure 28 millimeters mercury and diastolic of 13.8 on average. And out of 4,700, 72% of those patients in Pianist and 75% of the patients in paint were now controlled. Their blood pressure was actually less than 140 over 90. So yes, I think this is proof that these agents certainly reduce blood pressure within 4 months of taking the therapy. In the typical high-risk patient that we see every day. And of course, these differences were statistically significant. So it's also good to know. So regardless of which previous 2 drug therapy you were on, and regardless of the hypertension grade, you'll see that these agents give similar blood pressure reduction, blood pressure control, regardless of the grade, the changes in office blood pressure. So the point that these are effective agents to lower blood pressure is well supported by the study data. That was for office blood pressure. Of course, it's also important to look at 24-hour mean blood pressure reduction. So you'll see that at 1 month, that is the blood pressure, the systolic blood pressure at 1 month, compared to 4 months, the 24-hour, that's the mean drop. Of course, it was highly significant, both for the daytime and the nighttime values. I think the nighttime for me is especially an important time because this is the time also when most people, get their strokes or events like PND, atrial fibrillation, and even acute myocardial ischemia, patients with nocturnal angina who have obstructive sleep apnea, severe hypertension, they can actually go into acute pulmonary edema. So you do want an agent that works for 24 hours because you don't want to get to the nighttime and, the drug is gone. There's no more antihypertensive agent, although the patient did take their drug the early morning when they woke up. The third point is that we have outcome evidence for these 3 drugs, and I'm not going to go into the detail, but these are just the big trials. And I mean, if you look at those numbers, 12,000, 11,000, 3,000, 3,000, 19,000, with these agents, they work and they have been tested in large populations, giving you significant reduction in mortality, fatal and non-fatal stroke, and even myocardial infarction and fatal coronary heart disease in ASCOT. So there is proof that these are effective agents, also in different populations, whether they are diabetic, hypertensive, elderly, whether they had a previous stroke or TIA, or at least 3 risk factors. You'll see that these agents in combination definitely reduce the endpoints significantly. So there's proof that they work and that they reduce blood pressure. And of course, there's always this argument between ACEs and ARBs. It's true that ARBs give significantly less cough. There's no doubt about that compared to ACE inhibitors. But, and I think this is important for you to remember, that ACE inhibitors raise nitric oxide levels. And that's what you want, because that is an indication that you're keeping the endothelium healthy. So the endothelial layer, which is the inside layer of the blood vessel, is important because it produces nitric oxide, and nitric oxide reduces inflammation and it stabilizes plaques. So ARBs do nothing for endothelial health. But yes, they lower blood pressure. But there's no, although they do no harm, there's no evidence that they actually improve or reduce mortality in patients, for instance, with coronary artery disease and those prone to vascular events. We can talk about that later if you have any questions about that. Let's just quickly move now to the 2 diuretics that most of us know. So obviously, we have hydrochlorothiazide, which is the diuretic that all of us have in the state sector. In the Oslo and Mr. Fit study, there was actually a signal that it increases mortality and also the incidence of coronary artery disease. Although, and this is quite interesting, it did reduce blood pressure versus untreated patients. So yes, for the first 6 hours that you give the hydrochlorothiazide, it will reduce blood pressure. But the question is, may it also be doing harm? This was quite a big study, and there was a signal, although not significant, please look at that, but there was a signal that there was an increase in mortality and the incidence of coronary artery disease, presumably because hydrochlorothiazide is not metabolically neutral. It increases your triglyceride levels, which will then probably reduce your HDL. It also increases your uric acid levels, and in some patients may push them into diabetes. Whereas compared to indapamide, yeah, again, big numbers, you can see that there was a 29% reduction in fatal stroke, non-fatal stroke, all-cause death, CV death, and all-cause death and mortality. So this diuretic, indapamide, a thiazide-like agent, so it's behaving like a thiazide, but it's not, because it has true 24-hour cover. And I think that is why you're seeing the reduction in these endpoints because of the duration of cover of blood pressure lowering. So that's just that signal. So hydrochlorothiazide should probably be avoided as first-line therapy, and this comes from the American Journal of Medicine. Now, I know, the British National Institute of Health, the NICE guidelines, also said that the first choice should be chlorthalidone, which we don't have, or indapamide. And there they give reasons. Again, the antihypertensive effect that doesn't last 24 hours, and at its usual dose, hydrochlorothiazide 12.5 to 25 milligrams per day has never been shown to reduce the risk of myocardial infarction, stroke, or death. There was also recently a signal that hydrochlorothiazide may be associated with melanoma in European races. So you can quickly Google that if you don't believe me. I was also shocked to see that. But I don't know if that's relevant for African patients, because we obviously have higher UV light here than the people have up north, and darker skin as well, which protects us. There are randomized controlled trials with these three agents published already. And I've just given you there the references. And again, showing that these drugs are well tolerated as triple combination compared to dual combination. And obviously they give better blood pressure reduction and quicker control than other agents. Okay, the fourth reason is because the guidelines say we should consider them. The ESC 2018 guidelines said that, when we start treating a patient with hypertension, we should probably start with one pill in a dual combination, preferably an ACE or an ARB plus a CCB or diuretic. And you should consider monotherapy in the very elderly people or the frailer people with grade 1 hypertension. However, if the blood pressure is then not controlled, step 2 would be to start triple therapy. And this is where we see this agent being positioned as a single pill with 3 drugs, to help control better. I'm not going to talk about resistant hypertension tonight, because that's when we add spironolactone or spironolactone. And yeah, beta blockers should always be considered when your patient has heart failure, angina, post-MI or atrial fib, when younger women with planned or were planning to get pregnant or are pregnant. So the drugs also have a favorable tolerability profile. I spoke about the metabolic neutrality of indapamide. It does not interfere with lipid metabolism, carbohydrate metabolism, even in diabetic hypertensive patients. It also gives less hypokalemia and hyponatremia than hydrochlorothiazide. There you can see this incidence. And there was also, I think this is important, there wasn't a significant increase in uric acid levels with indapamide compared to hydrochlorothiazide, for instance. So it's nice to know that, especially if your patient gets one episode of gout and he finds out that it is a diuretic that's causing that, he is not going to take his diuretic anymore because it's most dry weekend this weekend, you know. So yes, the agent is available. My personal experience is that it works. I start low and I go slow. So we start with a 1.25, 5 milligrams. Please note these the combinations. So the first part is the Perindopril, and then indapamide, and then amlodipine. And they obviously come in 4 different strengths. So far, I have not needed to increase the dosage, to the highest dosage, because it seems that I do get very good control with a lower dose. So I start low and I go slow, and I think that is an important message for these beautiful cats, because they are very effective in lowering blood pressure. I thank you for your attention, and I'm looking forward to your questions. I think it's almost supper time for most of us. Okay. Thank you.
Thank you so much for that, Doctor. I think it was really enlightening for all of us that have attended. I see there are a few questions that have come through on the chat box, and I would encourage others to type their questions in the chat box, or you may lift your hand and then unmute once we have a chance. So, Doctor, with regards to the first question, is triple therapy now drug of choice, so no need to start with others?
Yeah, so as the guidelines say, we should preferably start, as the first step, we should start with dual therapy, and if the patient remains uncontrolled, then you should move to triple therapy as a single pill. I think the take-home message is single pill SPC, single pill combinations. Because you want to make things simple. Let's keep it simple and safe. The less tablets you give people, the more likely they are to drink them, and the more likely you're going to see effect with lowering blood pressure, and the less side effects you will see. I think that's the take-home message for me. So yes, there is a place for triple therapy. That would be for the 30% of patients that are uncontrolled, on the 2 drugs that you prescribed. That is where the triple therapy would come in. Although I've seen some trials recently, actually, I think it was published in the Lancet recently, where they actually combined 4 agents as a single drug and with low dose. And they also had amazing reduction in blood pressure with surprisingly very few side effects. So that is an important message, that, if you give these agents in low dose, you get less side effects, but you do get effective lowering of blood pressure without lowering it too low. So I always start at the lowest dosage. And although Servier does not recommend it, especially in my elderly people, I even make them break the lowest dosage as well. Initially, at least just for the first couple of days, until they get used to it, and then we take, the other half or the full tablet. And I have not had any side effects where people had orthostatic hypotension or, falls even, and it's a safe drug. I can vouch for that.
Thank you so much for that answer, Doctor. Just a reminder to those that don't have their full names on, if they could possibly type it in the chat box, because we do need the register for the CPD points allocation. So if your full name is not on, it may not reflect correctly on your CPD certificate. The next question is, could you please comment on valsartan as compared to Perindopril?
Yeah, so like I said, the ARBs definitely give you less cough. They are also safer with regards to angioneurotic edema. So as you know, with the ACE inhibitors, there's always this risk that the patient may develop angioneurotic edema and cough as well. And, you know, like I said earlier, cough is a sign that bradykinin levels are increased. So what I normally do before I initiate therapy, and my drug of choice always remains, unless the patient has contraindications, is the ACE inhibitor, Perindopril. Because I told you, you have 24-hour cover, and it increases nitric oxide levels, which helps to keep the endothelium healthy. So I tell the patient that this is why this is the preferred agent for me. Yes, the ARB or valsartan, if you want to talk about valsartan, certainly lowers blood pressure. That is true. It gives you less cough. That is true. It gives you less angioneurotic edema. That is also true. But there is no improvement in cardiovascular benefits. That is interesting. You know, it's almost like the hydrochlorothiazide data that I showed you. Although the blood pressure was reduced, there was a signal with hydrochlorothiazide, at least in Mr. Fit, that there's also harm. The ARBs don't give harm, they're neutral, but they also do not improve or reduce mortality. So I think that's an important point. So they remain my second choice. It's not my first choice. As a cardiologist, I see coronary plaques rupturing every single day. And I know it's like that because there's inflammation in that plaque. So if I'm going to give a blood pressure agent that can also reduce inflammation by lowering tumor necrosis factor alpha and apoptosis, which Perindopril does, I didn't discuss that data with you, but it does, that would be my drug of choice because it would stabilize the plaque. With the ARBs, I am not aware of any study that show that they improve cardiovascular mortality. So yeah, that's just my take on valsartan versus Perindopril.
Okay, thanks so much, Doctor. The next question was, what are the risks of, or what is the risk of hypotension with triple therapy, noting BP fluctuations during a 24-hour period?
Yeah, so like I told you before, I think the first point we need to discuss there is the SPRINT trial. I'm sure you guys know the SPRINT trial. Some of you, or most of you, should anyway. Published in the New England Journal of Medicine, and the take-home message is that lower is better. And the interesting thing is that yes, there were more lower drops in blood pressure that became symptomatic for the patient. That, you know, there were some falls, but these were not significantly more compared to standard therapy. In other words, aiming for not so low, i.e. more than 120 to 139 in that group. So my personal experience with these three agents as a single pill, like I said, I start low and I go slow. I have not seen any, even elderly people over 75, I have not seen severe precipitous drops in blood pressure with the drugs. And start low and go slow. You know, if you need to up titrate, you can eventually get there. But let's say within the first 3 months, 4 months, I would not increase the dosage until the patient is used to that single pill dosage. Also, if you do struggle with hypotension, encourage the patient to drink more water, especially with the warmer days that are still ahead, you know, to keep themselves well hydrated. And then obviously the issue of renal function as well. You may get a slight drop in your EGFR, but it would definitely not precipitate renal failure more than, for instance, Pyractin would do. So yeah, I think in that regard, it's a safe agent.
Okay, so just follow up on that, Doctor. So would you say that the side effects are actually less with triple therapy compared to taking them, for example,
as single agent?
Yes.
Definitely, you know, and that is just, I still have to get my mind behind that or around that, because why would it be? It's the same agents as a single pill, but you get less side effects when you give it in combination than if you would give them as separate agents. I do not know why, but it is true that if you give them as a single pill, you certainly get lesser side effects, even with cough, than giving them as separate agents.
That's quite interesting.
So,
Okay, so the next question was, can you use indapamide on a patient with a pacemaker?
you mean as a single agent indapamide on its own?
I don't have clarity on that question. It just says use indapamide. So
Yeah,
maybe from both, you could answer it from both as individual or triple therapy.
I think pacemakers are not a contraindication for indapamide. So yes, you can use it in a hypertensive patient if there are no contraindications. I don't know if that answers your question.
Yes, okay. I was just going through. I see there were a lot of people have been putting their names on.
The side effect of indapamide is irregular heartbeats. Can you still use it in a patient with the pacemaker? One of the side effects.
You mean for indapamide, that it would maybe cause a lowering of potassium and magnesium? It lowers those the electrolytes, as I showed you to you. I'll quickly show you again, but it's less than with hydrochlorothiazide. So I mean the incidence was less than 1% for the slow release. So for the patient who do get palpitations because of the drop in sodium or potassium or even magnesium, I would just then supplement that by giving them slow mag, or maybe a slow K or an extra banana, or that could work. So regarding the pacemaker therapy, remember the pacemaker obviously just prevents the heart rate from going below 60. That's all it does. So when there are ectopic beats, it would not fire unless, of course, there's complete heart block, and pacemaker is programmed to deliver therapy regardless of whether you get extra beats. Regarding atrial fibrillation, of course, again, it depends on the indication of your pacemaker. If the patient had a total AV block, if there is AF, it's upstairs in the atria, it wouldn't come to the ventricles. Ventricular tachycardia, yes, low magnesium may be a precipitant, but again, I can check the values or the levels and just prescribe slow mag. So I don't see any contraindication for indapamide therapy in patients with pacemakers.
Thank you.
Thank you for the clarity on that, doctor. If there is anyone else who has a question and would like to come on, you may unmute your mic. You can just announce your name and then ask the question. And I see there are two more questions on the chat. The one, I'm not sure if you would have this answer, doctor. It says, what is the cost of indapamide versus hydrochlorothiazide?
Oh, there's no doubt that hydrochlorothiazide is significantly cheaper. That is why it's the preferred agent in the state sector. So indapamide is more expensive than hydrochlorothiazide. But if you work it out on how many people discontinue hydrochlorothiazide because of side effects, let's talk about gout, for instance. And what happens because they stop the hydrochlorothiazide. This weekend in particular, I can tell you now, this weekend in particular, by Monday, so people stop drinking the hydrochlorothiazide from tomorrow, right? Because it's dry weekend, not dry day, it's dry weekend. And then on Monday, they have gout because, they drank so much alcohol over the weekend. But then just a day or two after that, they have a stroke, because they know that the hydrochlorothiazide makes the gout worse. And when they have a stroke, the cost for the state sector to treat that stroke is incremental. So there, it's like the medical aid companies, when it comes to cost calculations, Indapamide slow release is not that expensive, but the price that you pay for your stroke or your heart attack or your end organ failure is significantly more than the couple of rand that you would save by prescribing hydrochlorothiazide. And that is what most of our people in power still have to calculate, because if we can increase adherence to therapy, we will reduce cardiovascular endpoints. And more people die because of hypertensive complications than of COVID. As a matter of fact, hypertension is a risk factor for COVID. So I think there's no doubt in my mind, also coming from the state sector, and that is all we had. We only had hydrochlorothiazide. But I remember speaking to those patients and them, especially the male patients, reporting that the hydrochlorothiazide, they found out that it's that drug that's giving them gout. So it lowers blood pressure. It is an important agent to lower blood pressure, but in a patient with a metabolic syndrome, which is the type of patient that we see every single day, that would not be my drug of choice.
Thank you so much, Doctor. And the next one, the question is phrased, so Doctor, your first choice dual combo is, if you go for dual combination?
Yeah, so I'd go for Perindopril and Indapamide, or Perindopril and amlodipine. That's the dual combination. Yeah, so like I said, I always thought I speak to my patients when before I prescribe it. I say to them, you may experience cough, but because these agents are in combination, the side effects of cough would be even less than giving it to you as a separate pill.
Perfect, thanks. And the last question that I see on the chat, if anyone here we'll take one more question on the chat, but for this one that is here, can a patient on Spiractin and losartan be put on triple therapy? Would one stop Spiractin?
Right, so he's on ARB and Spiractin, and you wanna stop the Spiractin.
So the first, the first one is, the first part of it is, can a patient on Spiractin and losartan be put on triple therapy? So that would be the first part, and then the second part is, would one stop the Spiractin?
Right. So I wouldn't combine the ARB with an ACE inhibitor. I think that's point number one, because if you combine the ACE and the ARB, you increase the risk of irreversible renal damage. So you should never combine an ACE with an ARB. It was done in a study, and they found a significant increase in acute renal failure. And even when they stopped the agents, the damage was not reversible; it was irreversible. So that's the first one. If I'm going to stop, so the patient is already on an ARB and Spiractin, question is, why would I change? Maybe because the patient is having side effects with the Spiractin, maybe gynecomastia or hypokalemia. So we're already in the resistant hypertension ballpark. That is step 3, right? So at the moment you start thinking of Spiractin for a patient, you're saying that he has uncontrolled hypertension, and we're now at step 3 already. So we actually passed step 2. So to change them back, just to give them the benefit, we should start at the beginning with, the best drugs. So you must think before you write up your prescription. Why are you starting with what you're starting? And is it really benefiting the patient? And not just lowering the blood pressure. We should get past the point where we're saying, I'm prescribing an antihypertensive drug to lower blood pressure only. Because there are agents that can do more for you. And triplex is one of them.
Thank you so much for that, Doctor. The next one I see, it's just a comment, I think, no question. Redac, Moduratic, and HTC, same effects. And then there's a question after that. Is ACE inhibitor plus indapamide better than calcium channel blocker in indigenous Black patients?
Oh yeah, I was actually waiting for that question. That comes the answer from that for that question is from the Creole study. Creole was published in the New England Journal of Medicine. I'm proud to say that Prof. Mayosi, my mentor who's passed away, he was the second author in that study. So for us, it's a wonderful study. More than 700 patients, Black patients recruited, randomized to hydrochlorothiazide plus Perindopril, hydrochlorothiazide plus amlodipine, and Perindopril plus hydrochlorothiazide. So there's 3 combinations. And in essence, what they found was that the combination of Perindopril and hydrochlorothiazide did not lower blood pressure so much in Black African patients compared to Perindopril and amlodipine, and compared to hydrochlorothiazide and amlodipine. So, this is very interesting to me. Why would the Black patient respond differently to antihypertensive drugs? Many people say, well, because, of lower renin levels and all physiological differences. I'm saying that's nonsense, because, things have changed. We're not in the old Africa anymore. And because of urbanization, maybe, the kidneys are more salt sensitive as well. I think there's a demographic change because we see this drastic increase in the prevalence of hypertension. And did you know that, I spoke about sub-Saharan Africa with a 30% prevalence. Here in Cape Town, that prevalence is very close to 50%. So it appears that the further south you go, the higher the prevalence becomes in Africa. It's interesting.
It's interesting, doctor. Okay, and the next question, can a beta blocker be added to triple therapy if needed, like bisoprolol?
Yeah, so the beta blocker is always, as a cardiologist, what would I do without the beta blocker? It's my drug of choice for the patient with coronary artery disease, the patient with heart failure. That little block that I showed you. I'll quickly just go to the ESC guidelines. There you go. So if you have any of those indications, heart failure, angina, post-MI, AF, the younger woman, or those planning to fall pregnant, always you should consider them at any treatment step. So even at step 1, let's now say, they have angina, you should always consider, should I maybe, and again, I'd start low and go slow, 2.5, 5 milligrams BD, 10 milligrams. So yes, that remains a very important option for those patients and those specific indications.
Okay. And then the next one, I think it would come back to what we were speaking about earlier, the comparison of indapamide to low-dose hydrochlorothiazide in Black patients.
Yeah, so very good question. Again, hydrochlorothiazide, the duration of action. Like I said, hydrochlorothiazide does not give you 24-hour blood pressure cover. So don't fool yourself. Maybe for the first 5-6 hours, yes, the blood pressure will be lowered. But indapamide, even in the Black patient, gives you 24-hour blood pressure lowering and less metabolic side effects compared to hydrochlorothiazide. So I think even in the Black patient, unfortunately in the Creole study, they used hydrochlorothiazide and not indapamide. Up till today, I think cost was probably the issue and the drugs were donated. But it would have been nice if they rather changed hydrochlorothiazide to indapamide. But they didn't. They used hydrochlorothiazide because all over Africa, that's the diuretic that's being used because it's cheap and it's available freely, even in remote parts of Africa. So I think the relevance of using it in Creole is probably for that reason. But there's no doubt that indapamide is a thiazide-like agent that gives you true 24-hour cover. It's more expensive than hydrochlorothiazide, but certainly it gives you much better blood pressure lowering.
Okay, I see there are a few more questions. So just in the interest of time sake, we'll just go through them quickly. What is the incidence of postural hypotension?
With triplex-M?
Yes, well, I'm guessing it is. It just doesn't, it's not completely filled out the question. It just says, what is the incidence of postural hypotension?
Yeah, so since the drug came out, I probably have about 200 patients on the triple therapy, and postural hypotension, I'd say it's about maybe 2%, 1 in 50. So, but remember what I told you, I start low and I go slow. I don't start with the highest dose first. I start low, especially in the elderly, I go slow. And yeah, I get the, the one thing about the elderly is the issue of isolated systolic hypertension. So they have normal diastolic pressures, but it's only the systole that's elevated. And yeah, I've seen that this drug works amazingly well. It brings down the systole, but it doesn't bring down the diastole more. That's important because it's the diastolic pressure. Think about it quickly. The diastolic pressure that perfuses the coronaries. You don't want to lower the diastolic pressure too much because if you do, the patient will get angina. You need that higher pressure to push the blood into the coronaries from above. So there, triplicam is a perfect agent for me in the coronary artery patients, disease patients, because it gives you vasodilation, which improves coronary perfusion as well. So yeah,
Thank you.
I think that it works well.
Okay. I'm just going to go through the questions that were posted before H1. The next one is, should ACE inhibitors or ARBs be withheld on the morning of elective surgery?
Well, it depends on what kind of elective surgery are we talking about. I guess if you're talking about an aortic aneurysm that's getting prepared electively, it depends, So elective surgery, you mean like a gallbladder removal or what, cataract operation or? No, I wouldn't. I would still give it because most patients are very anxious prior, to surgery. So I don't think you'll get such a drop in blood pressure that, unless of course you expect the patient to bleed a lot during surgery, then I probably wouldn't give it on that day, on that morning.
Okay, and then the last two, doctor, should all type 2 diabetics who have microalbuminuria be put on ACE inhibitors as a drug of choice?
Yes, sir. It remains my drug of choice for the obvious reasons that I discussed regarding the endothelial dysfunction.
Okay, and then the last question, what will ACE inhibitor do if given in an episode of malignant hypertension?
It will certainly lower the blood pressure. I get the point that you want to quickly bring down the blood pressure, but here also you must be careful not to bring it down too quickly, because if you do that, you can precipitate what we call a water shunt infarction in the brain if you bring it down too quickly. It usually works if you take it, usually within 2 hours you see the blood pressure coming down, but it doesn't work that quickly. In the patient with malignant hypertension, we prefer the intravenous nitrates to bring down the blood pressure. The Tridol nitrosine infusion that we can titrate. And then we also, we give triplicam. I've used it in those situations, but again, I start low and I go slow.
Perfect. Thank you so much, doctor. And thank you so much for this enlightening presentation and, being available, answering all these questions. I do think that many of us will be leaving here with much more knowledge than we had an hour ago. So really thank you for that and for taking your time out to be present here with us. And thank you to all of our attendees who made some time during the weekday. A reminder that the Islamic Medical Association does have regular webinars. Our next one will be on Tuesday, the 5th of October. And that's actually quite an interesting one, also at 7:30, where we do have ethics points that have been applied for, and it will be around the POPI Act. Really, so for those who made it possible, our sponsor Servia, we would like to thank you, and really Dr. Marshall Radin, we really benefited. So thank you so much. CPD certificates will be emailed within the next week. If you have any queries, you may forward them to Kashifa Martin from the Islamic Medical Association. And thank you so much to everyone. Good evening and assalamu alaikum. Thank you so much.
Thank you, Zaifa. All the best to you guys. Keep well. Bye.
Thank you. Goodbye.
Bye.